So good evening to all. Thank you for the opportunity. Just this straight simple case starting with. Female, young female, history goes like this: a 35-year-old young female who was very obese. The BMI was 41.5. She had a pain over both hips for the past 1 year, and initial diagnosis of bilateral osteonecrosis of femoral was made, and right hip was stage 2, and left hip was stage 4. So the index surgery was done somewhere else. Patient presented to us in the OPD with the complaints of pain over the left hip. For what was done for right hip is core decompression with bone grafting was done, and for left hip hybrid THR was done. So she didn't have any initial X-rays or any scan in anything, but she had just a discharge summary report. And she presented to OPD with a pop zone from the left hip and difficulty in walking, and the pop zone was heard that regularly. Okay, and she did some maneuver of filling, which automatically reduced something. And she was not willing for any scan. So this was the X-ray that we have initially. So any questions? Hello? Hello? Hello?
You're asking our opinion, right? Okay, okay.
What
We'll ask this.
might have happened this part? Sorry, what might have happened here?
The cup looks vertical, and head is also eccentric.
But what might have been the reason why?
More of edge loading it is actually. So mostly you have to revise the cup actually.
Okay, sir. Okay. So that's what we actually suggested for her to go for a scan to see for the alignment of the inclination of the cup and the version of the cup. But she was not willing for any scan. She was actually completely like claustrophobic. She didn't want to go any scan. So what we advised was, okay, it has to be revised. Bear in mind that I told them, and she went out. After 1 month, one day she came suddenly with severe pain, and this was the X-ray. So has the cup moved, or that was our confusion. So under anesthesia, again the patient was
the cup has become loosened and moved actually.
Okay, sir. So what we thought was, okay, again we advised for revision in the first step. Then patient was not willing. So what, because of the budget constraints, so what we did was we did a reduction under anesthesia, and this was what we were able to achieve. So we stressed again to the patient, since she was an young patient. We told that again, you are going to have this problem of repeated dislocation. So it is better to go for revision, since the cup is also like goes loose. So that is what we told her. So finally we were able to convince her for revision, but we were not able to convince her for the scan. So now how to proceed, sir? So whether to go for a complete revision or just the acetabulum alone?
Get prepared for both and you decide on the table.
Okay, sir. Okay. So what we planned was, again, because of the budget, we planned for the cup and the head. We had full armamentarium, but our plan was to revise the head as well as the cup, because repeated dislocations, the head might also be damaged. So that was the plan. And if the stem version problem was there, or if stem was loose, to revise the stem also. That was the plan. We went in that. We went with complete revision set. Intraoperatively, what we found was that the medial wall was actually breached. We removed all the cement. It was very easy. The cement came out just in one notch. All the cement with the cup came out in just one bang. We didn't have any much difficulty in the removal of the cup. The stem was actually good. There was no loosening or anything. So we removed the head and the cup was removed, and we had a allograft got from JJ Davangri Hospital. So that we used to reconstruct the floor, and this is what we did. It's an immediate post-op X-ray, and it's a full pelvis in the follow-up. So what we revised was we used a multi-hole Griffin cup, and before that we reconstructed the medial wall with the allograft, and onto which we used a multi-hole Griffin cup with 3 screws. And the head was also changed.
Nice presentation.
And this was the patient at the end of follow-up. Patient is happy. She also lost some weight, but I've told to lose her some more weight. She's walking happily, doing day-to-day activities, back to driving even two-wheeler. Right hip is currently no pain. She's having good range of motion. She's able to sit on the chair, drive, and do her normal activities, take care of her baby also. Right, it's left hip.
So is that a ceramic head, is it?
No, sir. Budget can say have to use only metal on poly, sir. Metal head. Yes. Thank you.
Any questions from the forum?
So my initial doubt was what might have gone wrong, sir. For any female, they've used something like a cemented cup. So what might have happened, sir?
Yeah, the initial cup was also itself, it's vertical, I think, because of the view thing, and the difference is there. Okay, but it was loosened when you opened.
Yes, sir. I didn't need to bang much. It was loose. Just one bang, the cup came out with the cement completely. I didn't have to remove separate cements. The cement was also overhanging cement were there, but most of the cement was with the cup, and it was nothing done with the bone side, sir. I didn't do anything in the bone. It was completely came out as a single chunk.
It is 1 year.
Yeah. With the growth of uncemented.
1 month post-op, sir. When they
1 month,
presented at the time of surgery, it was 2 month post-op, sir.
Okay.
Maybe cementing would have given way, aseptic loosening would have come. Cement would have not fixed properly in the.
Yeah, because I mean, everybody's doing uncemented cups, so the techniques involved in sort of it takes a little more patience also to get things right when you do a cemented cup. You have to prepare the acetabulum better. You have to
Yeah.
try everything
Cemented
better.
is very tough than uncemented, sir.
Yeah, there are different techniques involved.
Yeah.
And then you have to get the mixing at the right time, and you have to hold the position accurately and not move around, because then again the whole thing can become loose. But the fact that the cup and the cement came off in one piece means that the interdigitation was not was not pressurized, because otherwise if the bond between the cement and the cup itself was wrong, then you would have had the cup just move out and then had to remove the cement with some difficulty at least. But since the cup and cement were together, is that what you said?
Yes, sir. All cement and the cup were bound together. Nothing
Yeah.
on the bone side, sir.
Yeah, so that means there's no interdigitation of the what they was described as a whiteout, where the transition between the cement and the bone should be such that you get a white mantle.
Just to think that I muted all the participants by default. Those who want to ask questions or anything, they have to unmute themselves and then ask the question.
Yeah, one more point for good cementation is even the anesthetist role plays a role, and they have to keep the BP well below 80 systolic when we are doing. And actually, like a total knee, where we take care in making sure that the cement goes into the crevices, as Dr. Ajit was telling, it has to go into the crevices. So that is the only thing which makes the cement get bonded. And also we should make holes, not just a small hole, 3.2 drill hole. It should be well above 4.5. So those holes, exactly as we are supposed to give it in the ilium, the pubis, and the ischium where they are, and those holes have to be made, and good 3 bones purchase must be there for the cement to last long and to survive. So the art of cementation is gradually being dying, and the youngsters, arthroplasty surgeons, they just get away by doing an uncemented and going.
Exactly, my friend. Can you just please, can you just more elaborate on cementing process? So like how for uncemented we use screws. So we should do something like this, drilling up and then
Yeah.
the hole.
So first is, once we have prepared the cup, which is always 2 millimeters more, we dry it. Ask the anesthetist to keep the BP well, because the immediate response will be to raise the BP when we say that we are going to cement. And we have to put a thin layer, not just a blob of cement. Before that, we have to make drill holes, which should be of adequate size, like 4.5. And it should be in the exactly, if a lot of holes should be made, but we should make sure that, because in the 3 areas zones the cement has to go, so that the cement has a very good purchase. So incidentally, today I happened to see what I did the exeter 21 years ago, the follow-up cemented, and the cement and the poly liner and the stem, everything is exactly, does not move. Today I've taken a photograph. So 21 years one side and 17 years the other side. So it is like the art of cementation, we must practice. So it will not come, we have to practice really, follow all the principles.
I have a doubt, sir. Um, do you rule out infection in such cases? Is it necessary to get a blood investigation? If so, would you go for hip aspiration in every case, or just a blood investigation and then go forward with the revision?
In this case, it was actually immediately post-op, and patient had we did the infection workup, and in this case, patient didn't have any other complaints except when the popping sound was there. Apart from that, she didn't have any complaints.
Okay. Okay, sir.
But generally, it is better advice to just work up for the infection prevalence.